Hello everyone. Welcome to the classroom. Today, I am going to show you some commonly used oral hypoglycemic agents, OHA. First class that we are going to talk about are the biguanides. The very well-known, metformin is from this class of medication. Metformin works by decreasing hepatic glucose production, decreasing intestinal absorption of glucose and improving insulin sensitivity, by increasing peripheral glucose uptake and utilization. Side effects of metformin include gastrointestinal disturbances and in some cases, lactic acidosis. Watch out if your patient has renal impairment, the dose would have to be carefully adjusted and renal function monitored. Next, let's look at the next class, which is the sulfonylureas. Commonly seen glycoside is one of the second-generation sulfonylurea. Glycoside stimulates insulin release from the pancreatic beta cells and increases insulin sensitivity at peripheral target sites. Glycoside is a good oral hypoglycemic agent. However, for elderly patients age 65 and above, glycoside has to be used with care to avoid hypoglycemia. Before moving on to the next class, let us take a look at this simple illustration. After food ingestion, GLP-1 is released by the small intestine. GLP-1 stimulates the glucose-insulin release from the pancreatic islet cells. It has also been shown to inhibit inappropriate post-meal glucagon release. Note that DPP-4 enzymes inactivates GLP-1. DPP-4 inhibitors work by inhibiting the enzymes inactivate GLP-1. They lowers HbA1c by 0.5 to 0.8%. They are excreted unchanged by the kidneys, thus dosing adjustment is recommended for renal impairment, except for linagliptin. Now let us look at another class of oral hypoglycemic agents, SGLT2 inhibitors. This class of drugs works by preventing reabsorption and facilitation excretion of glucose in the urine. SGLT2 inhibitors may increase urination. In females, there is a risk of yeast infection and urinary tract infections. These medications are also related to development of euglycemic diabetic ketoacidosis. However, these drugs are promising. They are shown to be able to reduce death and hospitalization in patients with heart failure and reduced ejection fraction. They can also help in HbA1c reduction of about 0.5 to 1% in 6 months. Pioglitazone. Pioglitazone lowers blood glucose by improving target cell response to insulin. This drug may cause or make heart failure worse. Take note before prescribing this for your patients. Lastly, we have Acarbose, which work by delaying hydrolysis of ingested carbohydrates and absorption of glucose. They can reduce HbA1c around 0.5 to 0.8%. Care need to be taken for patients with renal and hepatic impairment. Acarbose is not recommended in patients with creatinine clearance less than 25. With that, thank you. If you find this session helpful, please give us a thumbs up and do not forget to subscribe to this channel. See you next week.